I'm Charlotte Gill Patterson, and I'm a fellowship-trained breast surgical oncologist at Infirmary Cancer Care.
I'm Terry Hudson, and I'm a breast cancer survivor since 2013.
One of the biggest misconceptions is that it's a surgery or just one procedure, when it's really more of a process. So there's lots of procedures that you'll have to have done, lots of planning, lots of conversations, and lots of coordinating the timing and getting your expectations where they want to be. There are some things that make some types of breast reconstruction more complicated. Women that smoke or women that have some significant medical problems or some certain medications can make it very hard for us to do reconstruction, but most women are eligible for some form or some type of reconstruction. It's variable. Mostly we say 6 weeks of downtime, but it really depends on what reconstruction option you're going to have done. I like to tell my patients the more fancy we get with reconstruction, the longer it's going to take to recover from that. I think the biggest surprise that I see from patients have is that their breasts don't look exactly like they looked before surgery.
I had delayed reconstruction, so by my first follow-up visit, it was not in any way healed or anything at all, but the shape that you could already tell that you were going to have breast again, that you were going to be normal again. The changes that happened right away, while not perfect immediately, were definitely something that gave me hope. And so even at that first follow-up, to see the beginning of reconstruction was so healing to me, physically and emotionally. There are so many questions, and when you're first diagnosed with cancer, it's hard to make a decision that really is about your future. And the doctor knows by talking to you where you're going to be once you get past your mastectomy, once you get past your chemo. They can help guide you into planning for a future because you're so fixated on that initial diagnosis.
I think the biggest advice that I give my patients that are starting this process is to educate themselves. Know what their options are, know what's important to them, know what's important to their family members, but to remember that it's a very personal decision. What was right for your friend down the street or even a family member may not be right for you, and it's okay to want what you want. It's your body.
It is a personal decision, and you have to talk with your doctor about it and decide what it is that you truly want, and don't get so much influence from people who have strong opinions they want to share.
It's not a sign of weakness to want to have something that is perceived as a vanity or being a vain kind of issue. It's a part of who you are, and it's very important to you as a woman. It's important. It should be important to your surgeon as well. Most of the time we're talking about in the setting of having a mastectomy or having your breast tissue removed. The two main categories for that are immediate or delayed. Immediate reconstruction is where we do something at the time of your initial mastectomy. The delayed reconstruction means we remove the breast tissue and later we will do something. At that point, either the immediate or the delayed, we can put in a temporary implant called a tissue expander. We can sometimes put in a permanent implant, either a silicone or a saline-based implant. And sometimes we can move tissue on your body, either from your tummy or from your back, and move it around and create underneath that breast mound or that breast shape that will fill your bra. So there are so many options of reconstruction within that, not only the timing of when we do it, but how we do it. And there's pros and cons to all of those. And that's why it becomes a very individual and personal decision which one you choose, because they all look and feel differently. As physicians, from a cancer standpoint, we have to treat the cancer first. So sometimes the treatment options that we offer, like radiation, make it to where some of those options are less safe, and so we have to pull them off of the table.
That's true. Your treatment does sometimes dictate what options are open for you, but there are plenty of options. And as a patient, I had no idea what options were out there. And so it is very important to say, what is going to work for me? In my case, I did have radiation, and that puts you in a different sort of reconstructive category. And asking your doctor, what will that mean as far as my reconstruction? Just so you can get mentally prepared for different options that may be yours.
We know that less than 40% of women nationwide that have a mastectomy will be offered or undergo reconstruction, and it's usually because they don't ask or because they don't know it's available. So it is available here at Infirmary Cancer Care, and you should be able to have that option.
At the time you're newly diagnosed, you do think, it's not going to matter to me, just have a mastectomy. I don't want anything there to have any future problem. So while you think initially that, oh, that doesn't matter to me, I'm not going to care about that, it does matter. It did take a part of you. Physically, and personally, you've changed. So it's something that while you think you may not mind in the beginning and you're just worried about the medical aspect of it, do try to plan and do try to think ahead of how you'll feel every day. I talked a lot with my family. I needed positive reinforcement and encouragement to say, no, you may never be the same again, but you can be pretty, you can think about dressing up and going to the beach and all of that. And then once it gets going, it's exciting. You start seeing, okay, this is great.